Okay. All right. So this is a patient that was referred to me a couple of years ago. It's a 68-year-old male who had an interesting past history of a prior liver resection following a motor vehicle accident. That's all I know about that. But he actually had been complaining of ascites, abdominal distension, edema for the past 4 or 5 years, and has been followed with the gastroenterologist, including the liver transplant team. And also, interestingly enough, he's had atrial fibrillation for the last at least a year. And initially, he didn't really say very much to me about his symptoms, but after asking him a few times, he finally told me that he really couldn't walk more than about 200 feet on the flat, maybe 50 feet going up incline. And he says that it was because he was fatigued, or his belly was bothering him, or maybe his heartbeat was going too fast. And he's on apixaban, Lasix, and spironolactone. And on examination, his neck veins are up to the angle of the jaw, and he had distended abdomen, and only a little bit of pedal edema, but no sacral edema. So, in fact, what led to his referral was that they did a CT of his abdomen, and they looked up at his heart, and you see there's a rim of calcium over his RV. So, the issue was, does this guy have constriction? Well, interesting, despite the fact that he's never had an echo before. So guess what? Order an echo. All right, so on the top left, first of all, he's in atrial fibrillation, which always makes interpretation harder. You see a thick area, thickened pericardium, calcium. If you look at the septum, this is a septal shudder. And if you look over here, again, there's a rim of calcium, and it looks like there's some tethering of that thickened calcium. Now, his tissue Doppler, unfortunately, these were in perfect alignment, but this medial E prime is about 8.5, and this lateral E prime is around 12 or 13. So there's no reversal of these tissue Doppler, because normally the lateral is higher than the medial. So there's no annulus reversus. And his IVC, of course, is dilated. Now, I didn't interpret this echo, but my colleague said that this is likely constriction. So with that in mind, I thought he should go to cath. So a cardiac cath, let me just point out the hemodynamics. First of all, his RV EDP is 21, his LV EDP is 23, so there is a RV pressure is superimposed on top of the LV pressure. As the LV pressure drops, guess what? The RV pressure drops. And as the LV pressure goes back up again, the RV pressure seems to go back up again. So in fact, the two are moving concordantly, which is against the diagnosis of constriction. So what you really want to see in this diagram is the dark gray, which is the LV. On inspiration, you get a drop versus that at expiration. So the LV area gets bigger, but at the same time, the RV area gets smaller in the light gray. So that's ventricular interdependence on cath, which he did not demonstrate. So my colleague said no evidence of ventricular interdependence, said that there was a concordance pattern not suggestive of constriction, consistent with infiltrative or restrictive cardiomyopathy. Well, I said let's see a surgeon anyways. So he said, no evidence of ventricular interdependence. This last feature is the most important to clinch the diagnosis. Good chance that he would feel no different after pericardiectomy and the ascites would be unaffected. So he sent him for a biopsy. Biopsy was negative or nonspecific. So now what? I have a patient who has essentially class 3 symptoms. My cath didn't help. The surgeon's not He's giving me the cold shoulder. And, well, of course, it's time to do another imaging test. But I thought, I really should go back and do the echo again. I'm not happy with the echo. And let's go back and redo it again. And here it is. So this is with me breathing down the neck of our sonographer. And likely, or serendipitously, this guy came back in. He was in sinus rhythm. He was in sinus rhythm. And we have a respirometer, inspiration, expiration. And so first of all, the changes are subtle, but look at this arrow here during inspiration versus during expiration. So there is an inspiratory increase in the black space or the RV space. That's number one. But also look at every beat. There's a dimpling or indentation of the septum towards the LV in early diastole and late diastole. And this is the ventricular shudder. This is because the tricuspid valve opens first and pushes the septum the other way, and this is the atrial contraction, RA contraction first, pushing the septum the opposite direction. So there's two signs right here of ventricular interdependence. By the way, I should preface this by saying this is an M mode, and I know we don't do a lot of M mode anymore, but here we are where it clearly helps. Now the mitral inflow, unfortunately, did not show a drop, and it's pretty well consistent. The EA ratios are quite high, more than 2 to 1, relatively short decel time, but there's no obvious change in the mitral inflow with respiration. Now, that can be seen about a third of constriction, so that shouldn't alarm you. Now, here is the medial E prime. Now we have basically a better alignment. You can see that the E prime is a little bit over 12, and the latter one is a little bit under 12. So now, a very high E prime, medial E prime, this is annulus paradoxus, and of course this is greater than that. This is annulus reversus. Now, lastly, this is the hepatic vein flow. Again, inspiration, expiration is IVC, and there's our PW sample volume. Just note that during inspiration, that the forward diastolic flow augments. You see a little bit of reversal flow, but again, over here in expiration, you see that the forward flow now is reduced, and there's now augmentation of the diastolic flow reversal. In fact, this ratio to this ratio is roughly about 0.9. So, if you look at the Mayo Clinic paper from 2014, they featured 5 features of constriction, and here's the 5 with corresponding sensitivity and specificity for each of these findings. And so these are ventricular septal shift. This is the respirophasic shift, not the shudder, that also can be seen. A change in the mitral E velocity greater than 14.6, medial E prime greater than 9, medial E prime to lateral greater than 0.91, and this diastolic reversal velocity ratio to the, the diastolic reversal velocity to the forward diastolic velocity in expiration, this ratio greater than 0.79. So this gentleman actually had 1, 3, and 5. And look at these numbers. The sensitivity is not very good. High specificity. Look at the predictive value. Positive predictive value, 99%. Now, you got to be careful, of course, with positive predictive value, because in this study, 166 patients, 130 were confirmed constrictions. So there's a high prevalence of disease in this population. You know, in your echo lab, you'd be lucky if you see 1 case in 1,000. But still, I thought this guy had a pretest likelihood of disease before a second echo, probably around 80%, which is what the population was here. So I presented this at rounds, and I said to the surgeon, this guy had this positive predictive value of 99%, and he shows ventricular the anterior and diaphragmatic pericardium, which was stripped away. Initially, there was some alarm because his pressures, which were very high initially pre-op, didn't really drop right away intraoperatively. But more importantly, when he came off as a month later, he was now able to walk a kilometer. Don't forget, he couldn't walk 200 feet before. He lost 15 pounds. And then 2 months afterwards, he's walking now 4 kilometers. He lost 30 pounds, and his abdomen was way less tense. So just very briefly, go through this pathophysiology again. Don't forget, in constriction, you have this thickened orange peel that insulates the inside pressures of the heart from the outside intrathoracic pressure. So therefore, on inspiration, as your pressure in the thorax drops, your pulmonary veins, which are outside the pericardium, the pulmonary vein pressure drops, and therefore there's a reduced gradient into the left atrium, and therefore the LV filling is reduced, which allows for the septal shift. So this is all part of this ventricular interdependence. So this allows, of course, filling of the right side. You correspondingly see increase in the tricuspid inflow and reduction of the mitral inflow during inspiration. And during expiration, the opposite happens. As the pulmonary vein pressure goes up, now you can increase your flow across the mitral valve. Mitral inflow goes up, your tricuspid drops, and in diastole, as this septum shifts back the other way, the pressure now pushes blood backwards. So now you get this expiratory flow reversal. And if you can't remember all these complex interactions, just remember this: in restriction, you get an inspiratory flow reversal. In constriction, you get an expiratory flow reversal. So the mnemonic is RICE, R-I-C-E. Now, you know, you get a Kussmaul sign with constriction. And I just told you that inspiration is good for the right ventricle because you now can augment flow into the right side. So why do you get a Kussmaul sign, which means that your JVP goes up with inspiration? Well, just as there is ventricular interdependence, there's also veno-caval interdependence. So with inspiration, you can promote filling, but you also, of course, the diaphragm descends, your intra-abdominal pressure goes up, and you actually push blood from the IVC into the right atrium, right ventricle. And of course, it competes with SVC flow, and therefore this reduction of SVC flow. And you see this, if you do Doppler of the SVC, this is a different case. You see the inspiration. In this example, there's a little bit of reduction of the forward flow in the SVC, in systole and diastole. Most of the reports will say that there's not much change at all. And to contrast this, augmentation of flow in cardiac tamponade and for that matter in COPD, but this is actually a case of cardiac tamponade. And it's because, in cardiac tamponade, the pericardium is still thin, hasn't had time to thicken, and therefore, as you inspire, the negative intrathoracic pressures now can be transmitted into the intrapericardial pressure, and which, of course, transmit into the right atrial pressure. So just to end, here's the Mayo Clinic algorithm. Just focus on this part right here. Remember this guy, the surgeon and the cath doctors said that this guy could have restriction. Well, the initial echo had already shown E prime greater than 8.5 is what he had. So if you have less than 6, certainly think about restriction. 6 to 8 is a no man's land. And here's the 2 references. This is a great article to read. And most importantly, this is complex. And what I learned from this is that don't be afraid to repeat your echo. Repeat your echo with getting all your ducks in a row to look for all these things. And make sure, if you really want the surgeon to operate on your patient, make sure the words ventricular interdependence is on the final report. Thank you very much.